So this is what I call gaps and guidelines, and these are the centers that I have the pleasure of working at and work with my good friend and colleague, Dr. Bobby, who you met earlier this morning, who spoke on ET. So first, how did we get here? Mindful, this meeting started in 1999. I started my career, even as a medical student, I worked along with Ailu Teferi, who came to this meeting for many years, back in the early 1990s, trying to make a difference in MPNs. So let me share a bit of history. So one, these diseases have been found long ago, but it was the first kind of speculation of thinking of them as one family of diseases long before they understood the biology, back in the 1950s. And a very famous hematologist, Dr. William Damashek, was the one who kind of coined the term at that time of myeloproliferative syndromes. Now, over time, he had a longer list, some of which we continue to think of in the MPN family, and some of which we do not for a variety of reasons, based on different biology. So chronic granulocytic leukemia became chronic myelogenous leukemia, and it is in many ways a cousin of the MPNs, but has a very distinctive biology, a very different treatment, so we think about it in different ways. And there were other diseases that he speculated were related, which over time we learned biologically were not. Now, our therapy has come a long way in a very short amount of time. As Naveen was alluding to, I could think back on my career, and really the dividing line was the key discoveries in the biology of the disease. The discovery of the JAK2 mutation. Because prior to that, all the therapies we had used had largely been begged, borrowed, or stolen from other diseases. Naveen wasn't kidding when he said that we actually use an anti-helminth or an anti-parasitic drug that inhibited TGF-beta to try to see if that could impact fibrosis. So we were again trying to explain to infectious disease doctors why we wanted to use this drug, in MPNs. And then after the JAK2 mutation was discovered. Now, we have had a lot of philosophical thoughts over these decades. With ET and PV, what is our goal with treating the disease? Historically, it has focused on controlling the risk of blood clots through the control of counts or some degree of anticoagulation. And only now, as you heard from the very nice talks from Dr. Rampal and Dr. Bave, are we starting to feel that we're having some impact on the biology of the disease, and hopefully more so in the future. Myelofibrosis, prior to the JAK inhibitors, our therapy really was very limited. There was tremendous talk of something we don't even discuss nowadays, which was surgical removal of the spleen. There were whole papers, analysis of this surgery. It was a surgery that was dangerous, surgery with many complications that, again, we largely have decreased its use over time. The evolving role of stem cell transplantation, and we'll take a deeper dive in that with Dr. Palmer later after lunch. Many attempts at improving anemia with some effect, but still a ways to go. And we really had nothing that really impacted symptoms. Now, these meetings kind of grew up in parallel with the evolution of our understanding. And in many ways, I think the collaboration between the MPN patient community and investigators has helped to accelerate progress. So it was at this meeting in 2003 when Gary Gilliland at the time brought his postdoctoral fellow Ross Levine to the meeting, and they made the case for folks, if they were willing to donate blood, that they would study the blood to try to learn more about the disease. And indeed, Dr. Gilliland was one of several labs, along with that of Dr. William Menchenker, that discovered the JAK2 mutation, but in part by being able to study the blood from many MPN patients and find those key mutations. Other innovations as it relates to assessment of symptoms, non-pharmacologic interventions have been important. Indeed, you'll see out there in the lobby there are some of my collaborators working on a study, if folks are interested, around meditation and sleep as one such example of other collaborations to try to impact the other aspects of the disease. Now, as in all diseases, the understanding of the biology of the disease is so key. And we start the conference with the wonderful comments from Dr. Nangalia, not at random, but that really is a bit of the fundamental foundation of how progress is made. And there are still gaps in understanding the biology, which is why we don't really have it fully figured out yet. We've made progress. You know, I use the analogy, it's a bit like a jigsaw puzzle. It's got 500 pieces, but you've got 250 pieces on the board. And the other pieces matter. And every day we could put another piece, someone finds another mutation. We don't quite know how it fits in. You know, we know DNMT3A is common. Is it relevant? Is it not relevant? It's put on the board. And these things are important to try to answer. Why does it start to begin with? Why does it progress? How can we leverage that knowledge to make a better impact in terms of therapy? Now, indeed, this is kind of the core, and you saw this from Dr. Nangalia, so I won't go through it at length, but really, we need to, as we truly understand why we make blood cells and what drives that and what controls that, and then what is different to then end up in a disease. And why are the diseases different? What are the things that make a difference between them? Now, every one of these additional pieces is incredibly important. As you heard from Dr. Bave, and you'll hear further from Dr. Mascarenhas, we had historically always treated patients that had the calreticulin or CalR mutation in the same way as those patients that had MPL or JAK2. But in the future, it is possible that that will be different, that there are therapies that are being specifically developed for the CalR mutation. And again, over time, we may learn that although these diseases look very similarly, there may be differences which are very important in terms of how we treat them. You'll be hearing further tomorrow from Dr. Stefan Kashmir as it relates to inflammation. So again, we're learning more about biology, changes in mutations, but what we realize is that there's also significant issues of inflammation and other drivers in the disease. Now, MPNs are not one thing. And clearly, as I look around this room and have interacted with many patients over the years, nor are you as a community one homogeneous group. There's teenagers, there's folks in their 90s. There's individuals that have a lot of difficulties with their disease. There's others that it's found at the time of a routine physical, and if they weren't told they had the disease, they would have no idea. So when we visit with an MPN patient, we realize every individual is an N of one. You are all unique. We have to be mindful of how does the disease affect you specifically? Do you have symptoms? Are your blood counts low or high? Have you had a blood clot? Have you had a blood clot before that still impacts your health? What about the rest of your health? Are you having symptoms? Are you on medications? All of these things factor in. And it's very important as we think about precision medicine. Precision medicine in our world has become a synonym for understanding the molecular changes one individual faces. But as we learned over time, there are many more individual factors which are important. Now, Naveen had alluded that we had developed an MPN symptom tool. And actually, this really came from working closely really with Joyce Niblack, from which this conference is named. Because it was Joyce who challenged me in the late 1990s to try to better understand the symptoms. She's like, Ruben, she's like, we don't feel well, but many of us do not externally look ill. And with this, one, it leads to an under recognition of what we're feeling. And two, the symptoms probably are telling us something about the disease. And both of these things ended up being very true. So we developed these questionnaires, and again, they go through a process just so that we're certain people understand what's being asked. Do people fill them out in a consistent way? If you change something for the better or worse, do the scores change so that you can measure a change? We now have data in thousands of patients, I think at last count, almost 40 languages from around almost 100 countries in which individuals have filled out these forms. And what we've learned is that the ranking of symptoms by disease is almost exactly the same globally. So you can compare Madagascar, Uruguay, or Phoenix, and you will know that fatigue is the worst symptom. And you'll know that other symptoms are more rare. Now, interestingly, there is a definite cultural impact on severity. People may have a different tendency in terms of a higher number or a lower number. You get closer to the Mediterranean, the numbers go up. You get more into Scandinavia, and the numbers go down. But the ranking is still the same. So I still offer for someone out there a PhD in anthropology that clearly could be gained from an analysis of this data. Myself, I just got too much on my plate for that. But there's cool stuff to be learned there. Now, another thing we learned is that MF is not the only disease that has symptoms, very clearly. So you see here, MF is in green, so as a group they are more symptomatic, but any one individual ET or PV patient might be more symptomatic than any one MF patient. People would ask the question, well, I'm tired. I got to drive my daughter to ballet. I got to do this. I got to do that. MPN patients say they don't feel well. Cry me a river. I don't feel well either. And I have physicians that are MPN patients that are like, I never thought the symptom thing was real. And then I got the disease, and I found out I was wrong. So our colleagues in Ireland actually did an age match control and found that indeed for every individual symptoms, MPN patients are clearly more symptomatic than the general population. Now we have found that fatigue is higher in the general population than the other symptoms, but the MPN patients are even that much more fatigued. But this has been relevant as we've analyzed clinical trials, that fatigue is its own unique thing. But the baseline fatigue level is not zero, really, for most adults. Now, there's another very influential, important MPN patient, Zen Senyak, who came to this meeting several times as well, who challenged and said, Ruben, I do wonder whether how much of the MPN symptoms is really because people they're anxious, they're depressed, they don't know what's going to happen next. Maybe that's the cause. And I'm like, well, this is something we can study. So we looked at this. Again, is it one or is it both? And to some degree, there can be features of both, as we'll share with you. One, there's clearly biology. So this in red is high. These are cytokines or markers of inflammation in myelofibrosis. So very high. And over time, we've learned that there's a variety of different changes in cytokines that both can be related to symptoms as well as features of this disease. And you'll hear more about this from Stefan in his talk tomorrow. We've learned that there's definite tie to the biology. Again, if somebody is having itching, for me, that's just like, fever with infection. It's just another sign of the disease. It's real, it's biologic. We know that the white cells migrate to the skin, and they're part of that story. I know that bone pain, severe bone pain, is unusual with the disease, and that can be its own sign of the illness, or night sweats, or inadvertent weight loss. Abdominal symptoms can have multiple different drivers, and as can constitutional symptoms. I know that if a patient is having measurable fever, let's say fever of, over 38.7 Celsius, that can be a concerning sign of actual disease progression. And we know that some symptoms really are related to high counts. Because as we speak of blood clots, there are many symptoms that occur prior to a blood clot. I view the blood clot as like the extreme. So if I use like a traffic analogy, if the highway patrol have blocked off the highway and everybody's got to get off, that's a blood clot. That is your driving, worst nightmare. Those are brutal. Whereas traffic is what we experience more. Headaches, tingling, erythromelalgia. The blood's getting through, but it's slower, and there's a consequence. So again, as we think about individuals, precise and personalized care is a crucial piece of how we really try to tie these things together. Now, what are some of these gaps? Well, as we think about ET, you heard a wonderful talk from Dr. Bhavi, and we still have some important gaps. So who needs treatment? The better the treatments we have, the more we will evolve to everyone being treated. The moment you hear a medical discussion of who should we treat, that is code word for we don't have a good enough therapy. Because the moment we have therapy, there is no prognostic risk scores for deciding who is treated for strep throat. We don't have a prognostic score for deciding, who gets an emergency angiogram when they're having a heart attack. Everybody gets treated. So the better the treatment, the more everyone gets treated. 2, it speaks of controlling cardiovascular risk factors well. And I don't think we necessarily do a well enough job with this as a field. We clearly need more therapies. With each of these diseases, you can count the number of FDA-approved therapies on one hand and typically have a couple spare fingers. And in ET, actually the only approved drug is no one's favorite, anagrelide, is the only approved drug for ET. Hydroxyurea is actually, which is a good drug. I don't hydroxyurea is helpful in certain circumstances, but it's actually not approved in MPNs. It's actually approved mainly for things we don't use it for. It's approved for head and neck cancer, as a radiosensitizer. It's used in ovarian cancer. It's used in CML. Actually, we don't use it in any of those things anymore. So we clearly need better therapies. And then with ET and PV, a very critical piece, why do people progress? And how do we stop that progression? Certainly there's a sense that interferon helps with the issue of progression, so that is relevant, although I don't think we fully understand it. Now in PV, you heard the wonderful talk from Dr. Rampal, and the same issue is the same as ET. Who really needs treatment? There's some that which we only use phlebotomy and aspirin, and that's still a historical artifact because we wanted to limit the use of hydroxyurea. That may continue to evolve over time as we have different therapies. Management of cardiovascular risks, more therapies, and progression. So in PV, for example, again, as we think about this issue of risk, I like to think with all these diseases, we not only think of risk, but that we also think of the burden of the disease. Because in P-Vera, you might have not a high risk of blood clots, but you might have many symptoms. Again, I'll have colleagues who say, boy, if I need a phlebotomy, I have headaches, I can't concentrate, I can't do my full length of clinic. So even if that individual doesn't fall in the high risk category of PV, they are having a negative impact. Or let's say, I get phlebotomy, but every time I get phlebotomy, my arm is sore, they have a hard time sticking me, they stick me 4 times, I'm lightheaded, I have to have somebody else drive me, the next 2 days are trashed. These things can have a real consequence. Also, as you'll hear about the new therapies for P-Vera, the issue of phlebotomy, which again has had a very beneficial impact, but a limiter is that it's a bit like a yo-yo. Is that your hematocrit goes up, we phlebotomize you, your hematocrit goes down. It goes back up, it goes back down. This has, I think, several negative consequences. One, you spend a lot of your time really above the target hematocrit. 2, you really have uneven control, which I think is both hard on symptoms And then 3, you require the development of iron deficiency, which can lead to its own additional symptoms. Now, for me, the biggest unmet need in terms of biology, people say, what do we need the most? We need to understand why people progress. Because if we truly understood why people progress, this could be a watershed in a variety of things. If you're on P-Vera, on interferon with a goal of trying to avoid progression, do you need more? As we start these new therapies, are they having an impact on decreasing progression? Are you at low risk of progression and we're perfectly fine treating you just as it is? What about myelofibrosis? Again, gaps, still the same issue of who needs treatment. We probably stem cell transplant. When do we do it and in whom? I think we probably still transplant too few patients. The JAK inhibitors are helpful, but again, how do we optimize them? This issue of progression even more relevant. And then how do we get to a broader and deeper impact? Indeed, in transplant, I'll just say a couple comments as this comes up with Dr. Palmer later. There's a few kind of key facts. And anyone who says that the decision for making a transplant is easy is not the individual facing that decision. First, the first fact I would say is that the ideal time for transplant is probably before you progress. 2, in terms of progress from MF to more toward acute leukemia. Second, medical therapy probably pre and post-transplant is likely the future state. Delaying transplant likely increases transplant risk and poor outcomes. And fact 4, and this is crucial for any of you that have this discussion, your personal opinion and philosophy regarding your healthcare is central in this discussion. I will have 2 individuals in my office who are both 65 with both the same risk. One will decide on transplant and one will not, and neither one of them is wrong because it is such a complex decision. Now, Naveen showed you this, which looks a bit like the Tokyo subway map. And it both gives me tremendous hope, but it also shows you a bit of the complexity of what we're dealing with. Because if you think about this, you see there are many, many things going on at the same time. And part what challenges us as researchers is it's a bit like if you were to turn off one of these, how do the others respond? These are not like single streets, but there are multiple things kind of going on at once. If we shut off one gene, does something else compensate? Do we need to turn off multiple genes? Do we do them all at the same time? Do we do them in sequence? That's why the advances in research are so crucial. So to put this together, we have been undergoing something that's really been known as the cancer moonshot. And in many ways, MPNs really are a part of this same effort. And eradicating the concept of cancer as an illness is probably the wrong goal, in part because the process of developing cancer is so inexorably tied to the process of aging that no one developing cancer is probably an impossible goal. More importantly, how can we change it so that the things that really make it negative and harmful are able to be better controlled? Earlier detection, more effective therapies, more equal access to therapies which are available, better understanding the complexity of the disease to be able to better treat individuals. Now, for MPNs, I think team-based care is crucially important in these diseases. If appropriate, a cardiologist. Dermatologists, almost certainly. One thing we never discuss enough, issues with the skin, both from medications, age, and having MPNs, particularly as we age, are really, really relevant. Some individuals, again, have had a liver doctor or other. One or multiple hematologists working together. But also, folks really helping support the rest of you as an individual. depending upon where you are in that journey. That might be a nutritionist, that might be a physical medicine doctor, that again may be a psychologist, just helping you deal with the uncertainty. There's an uncertainty of kind of what's going to happen next. We all have this right now at the moment, irrespective of having an MPN. We never know what the next news cycle will show. That anxiety has its own impact, and again, how we try to manage through that. The second is really, how do we really learn from the totality of what's going on? And there clearly is progress in this regard as well. How do we learn more from kind of the global experience of MPN patients to be able to understand how to better treat folks? So in many ways, the way you have to think of things is that part of the goal today, but part as you walk this journey, is that the journey from illness to wellness is not necessarily the complete absence of disease. Indeed, I think of many individuals that have a curative procedure for disease. They've had a surgery for a breast cancer or colon cancer, and undoubtedly some of you have experienced these things as well. Just the absence of that cancer does not mean that they are well. Wellness includes all other aspects as it relates to your health, your fitness, your relationships, your family, in addition to those things which we bring from medicine. And with that, I really would like to thank all of you. The progress we have made in MPNs is only because of the engagement and close collaboration of the MPN community. I think about the tireless efforts of the folks who've been leading the MPN Education Foundation, starting with Joyce and Bob, but David, Joanne, and everyone else here, Anya, who's not with us today, and many others who've given so much tirelessly of their time to help others. Clearly, all the collaborative efforts, all the individuals that have elected to participate in clinical trials. Every progress we've made has really been only because people have been selfless enough to say, boy, I hope this trial helps me, but if it doesn't help me, I hope that it helps someone else. And I'm sure I see my colleagues nodding, knowing that, again, every patient that's enrolled in a clinical trial has really brought that sense of altruism to that along with them. So with that, this is just a typical day for me in the beautiful Blue Ridge Mountains there. This is a lovely spot called Blowing Rock. And with that,